Hi, I'm Tamara Thomas, Editor-in-Chief of Urban Health Today. I'm speaking with Joseph Wiemels, Ph.D., Cancer Epidemiology Program at the USC Norris Comprehensive Cancer Center. He's here to talk about early onset cancer incidence and first and second degree genetic predisposition among Latino, African American, and Asian Pacific Islander families. Thanks for talking with me today, Dr. Wiemels.
It's a pleasure to talk with you, Tamara.
Awesome. Let's get started. So, can you talk about the study itself and the basis for the study? First of all, what is early onset cancer? What is that defined as?
Sure. There are different definitions of early onset cancer. Pediatric cancer is typically up to age 15, or sometimes people define it as up to age 19. In this study, we went up to age 26. And the reason for doing that was because we had good population records back to 1988. So we kind of covered the time period from 1988 up until 2015. And, we would have done more. Young adult cancer is typically up to age 39. And when we're looking at strongly genetic cancers that happen early in life, usually people will cover up to age 39. But we were not able to do that simply because our cancer records in California started in 1988.
And so how did the study, what was the basis for the study? What made you decide?
Sure, yeah. The basis of the study, it's kind of an interesting story because it wasn't something that we just dreamed up from scratch. It was sort of an observation of a colleague of mine. Her name is Lucy Godley, and she's one of the authors of the paper. Lucy Godley works in Chicago, and she works on family-based cancer genetics. So she collects families from around the country. She's kind of a referral. People will refer to her when they have a family that looks like they have several members of early onset cancer in that family. They will refer those families to her, and I think she probably has 700 or 800 of these families. And one thing that she noticed was that there were a lot more Latino families in her database than she would have expected based on the population size of Latinos in the US, being a minority population. She's, why do I have all these Latinos? And when we were having this conversation, and she was telling me this, I'm like, well, California is one of the 2 states with the highest Latino population, the other being Texas. And it's about time we saw if this is something that's really true at the population level. So, and the really nice thing we can do in California is we can link our registries. We can link the birth registry with the cancer registry, so we can define or describe the way cancer incidence within a family at the population level, where we can capture every single cancer case in the state. And this type of study where people look for cancer within families, it's really only been done in European origin populations in the past. So Sweden has done quite a lot of this research because their population database goes back probably 2 centuries, so they can track cancer within families at a really high degree of accuracy. But their population is somewhat small. It's about 10 million. In California, we have 40 million people. So, and the other thing we have in California is a wide mix of populations. So it's not all European origin. So we have our largest birth population are Latinos in California. And we also have significant numbers of African Americans and Asian Pacific Islanders.
Do you anticipate connecting at some point? So I'm thinking about Chicago, and then Chicago reached out to you. Do you anticipate connecting with other states' registries in the future to expand this information, this database?
Yeah, we would like to, although California is set up in a way that makes this type of research fairly straightforward. They really support this research well, but obviously we're not catching everybody just looking at California. We know even if our focus is only on Latinos, we know that California Latinos are predominantly Mexican origin and South America origin, whereas East Coast Latinos have a different genetic ancestry or different genetic makeup. So we really would like to be able to cover other areas in the country. Another reason for doing this research in California is we can access neonatal blood samples, so we can actually try and sequence and understand what the genetic basis of this familial clustering is. And not every state in the US allows that or saves these neonatal blood spots for research. So Michigan is one, New York is one, Washington State is one. So those might be other states that we would like to be able to extend this kind of research.
So your study identified solid tumor and blood-based cancers among family members. Did you find certain types of cancer clusters? Were family members being diagnosed with the same kinds of cancers or with different cancers?
Right, we saw a combination of both. And we think it's probably different genes that are involved. A classic example of family-based cancer clustering is a rare cancer called retinoblastoma. It's a cancer within the eye, and there's a specific gene which is responsible for this. And so for nearly every family that we saw where there was a retinoblastoma in more than one family member, it was all the same cancer. They didn't have other types of cancer. But for most cancers, we see one child with a sarcoma, another child with a leukemia, one child with a brain cancer, another child with hepatoblastoma, or different combinations. So we think that these the reason for that clustering is genes that are more, one word is promiscuous, where a single bad gene can actually contribute to different types of cancer. Although we do have families where the cancer types are all the same, whether they're leukemias or brain cancers. Okay, so the way the statistics work is we look at the incidence of cancer. So this is not comparing the overall incidence of cancer. It's comparing the incidence of cancer that occurs within the family. So 2 or more cancer cases in young people within a family. And what we do is when a child gets cancer, then we follow the rest of the family from that point. And we estimate cancer risk in the siblings each year that a sibling is tracked in our database. And also the mother. We also look at the mother, see if the mother gets early onset cancer. And then if one of the siblings does get cancer, that's compared, or actually amongst all the siblings, we look at the rate of cancer within a subgroup, within one of our subgroups, whether they're the ethnic defined subgroups. And if that incidence of cancer is higher than the population rate of cancer, that we get a number for that. And pretty much for every cancer, we found significantly higher risk of cancer in siblings once there is a sibling identified with cancer. So that means that, for pretty much every cancer, if one family member gets cancer, the rest of the family has a higher risk of cancer. And that's not new information. That's something that came out of these Swedish studies years ago. Mm-hmm. But what we found here is that when we looked at that risk in siblings and young mothers, it was significantly higher for certain cancer types in the minority groups that we looked at compared to the European origin or the white children in our study. So the difference I'm just looking at some numbers now to give you an impression. So for whites, if there's a proband with solid cancer, a proband is one of the siblings. The first one who gets cancer, we call a proband. Latinos have a 5-fold excess risk in siblings and mothers, and non-Latino Blacks have a 7 over 7-fold risk of having other family members getting cancer once there's a proband with cancer. That's for solid cancers. And for hematologic cancers, those are blood cancers. The highest familial risk was in Asian Pacific Islanders, which was about a 7.5 times excess risk of cancer in other siblings if there's a hematologic cancer in the family. For whites, that was 2.7. So the difference there is 7.5 compared to 2.7. So you can see that's almost a 3-fold excess for hematologic cancers in Asian Pacific Islanders. I forgot to give you the white number for solid cancers. For non-Latino white subjects, the incidence is a 3-fold excess risk if a sibling, if a proband has a solid tumor, then another family member has a 3-fold excess risk. And that's the one where for Blacks, it's 7.4-fold excess risk. So that's more than double. And for Latinos, it's a 5-fold. So it's 5 compared to 3. So that's less, less than twice for solid tumors.
Wow.
So that's kind of a nutshell.
And why do you think this is so frequently found in people of color? First of all, I should have asked this before, but I'm going to kind of include it with this question. Is this, all things being equal, socioeconomically, neighborhood-wise, is the data, when you're comparing the data, are those things equal, or are you finding different socioeconomics?
Yeah, so for this particular analysis, we're not looking at socioeconomics at all, or other environmental exposures associated with SES, or people's professions, or air pollution, or pesticides, or any of the other risk factors that we know play a role in childhood cancer. We're simply looking at the families. So it is possible, and it's probable that some of this excess risk that we're seeing in families is because the whole family is being exposed to some environmental exposure, or some other feature in their family unit that's giving them risk besides the genetics. So genetics that's typically what researchers have focused on when they see excess risk within a family. But it's possible that some of this excess risk we're seeing is because that family they're all getting exposed to the same things, right? They're in the same household, they're eating the same food, and their neighborhood has obviously the same characteristics since they're all living together. So this, I think, is a really important thing that our study has not touched on at all, and what we need to study, and what we are going to study in the future, is are there other reasons we're seeing this family-based clustering. And in the past, my research has always imagined that people are living, the basis of it is that we're looking at unrelated individuals. We have several studies where we look at cancer on a big scale. We have a childhood leukemia study with 5,000 children in it. We have a brain cancer study with 3,000 children in it, and nobody's related to anybody in those particular studies. So this is the first time we've kind of focused on families, and to see this family-based clustering. And in our other studies, we look at exposures as well as genetics. We try to estimate exposures by where people live. So we look at where they live, what the air pollution, how their proximity to roads and traffic fumes, their proximity to farms, how the weather will take the exposures from pesticides that are dumped on farms and pass it to the household, so that we can see exposures for the mother during pregnancy, for the child as they're growing up. But what we want to do in the future the very near future is try to combine these approaches where we can look at these family-based studies, we can look at the exposures, and we can try to estimate how much of this cancer causation is possibly caused because they share genetics, and how much of it is caused by the fact that they share the environment, and there are features of that environment and that have contributed, or is it the two things together? Is there sort of a genetic vulnerability in these families combined with living in a less, a poor environment that together provides this excess risk? Because the one thing about environment, that's something that we can hopefully modify. We can't do a lot with our genes. That's something
Right.
we have. I mean, we can make family planning decisions, but we can't remove or alter our genes.
This can't, you have 20 something odd years of data. I wonder if you went further back, would you see those cancers? I'm not sure that you would. Do you think that you would?
Well, that's actually a really good point. One thing about childhood cancer is, in the past, if you had a cancer as a child, you wouldn't pass on those genes, and because you wouldn't survive, for one thing. Nowadays, it is possible to survive, and oftentimes it's possible to pass on the genes as well. Although some children, because cancer involves a lot of therapy, chemotherapy, and radiation therapy, that some really don't have the ability to reproduce. But yeah, that's something that's different than adult cancers, where most of adult cancers occur after people get through reproductive years of their life. Mm-hmm. So it's more likely that the genes are passed on. But we actually are sequencing some of these families now, and we found that some of the genes that are turning up many of these clusters are from strong cancer predisposition, because we can find the genes. They're known genes to be involved in cancer predisposition, and some of those genes are also involved for adult cancers. So it is possible that the children could have survived childhood okay, even carrying these genes, but then may have had a higher incidence of adult cancer as well.
Your study concludes that the data could help healthcare providers and genetic counselors offer more precision-based care in medicine and advice. Now, of course, that's provided they can afford it. We haven't gone into the socioeconomics because you didn't look at that, but I am curious about that, because precision-based care, you have to have good insurance in order to attain it, to get that, right? So, but the thing is, it's sort of becoming evident. I mean, you've got this study within the medical community, and maybe, to some extent in the research community, that there is this inequity. So in light of this, how does this become actionable information? How does this go from important data to better tracking and eventually prevention, saving lives? How do you envision? And that's a mouthful of a question, but if you will.
Yeah, no, that's a good question. So I have been talking with a genetic counselor at the LA County Hospital, which is right across the street from where I work. So I work at the USC Medical Center. It's on the east side of LA, and it's right next to the very large county hospital. And the genetic counselor that I know there, it's predominantly Latino families, because it's a very Latino neighborhood, and for her, it's a kind of a realization that this is a fact, or this is something true about the families that she serves. And we've been discussing ways, well, how can we get this information out to other genetic counselors? And it turns out there is a network, as you might imagine. In every profession, there's a network of the ways that people interact with each other. And so we've been discussing how to create a, the way we do research is we start out with these ideas, and then we put together a grant proposal, and we send that to NIH. And this grant proposal would be, on the one side of it, doing the research to try to discover why there is this excess familial risk in these groups. And that part of that will be where we look at the environmental risks as well as the genetic risks in these families to define how much of it is one or the other. And then the other equally key part of this project will be to get the information that we find out into the hands of people who can use it, namely genetic counselors who work within such communities, so that they will have a realization that when they speak and they interact with families, they need to get this information back to families. You know, we found that there's a higher risk of cancer of other members in your family because of your first child with cancer, and there are ways to counteract this risk or to reduce the risk in your family, and also just whether or not that family decides to do some kind of genetic testing to see if there is a predisposition gene. Well, we have to know from the research side whether there's likely to be that cancer gene or not. So the project that we're doing will really try to assess the prevalence of the genes that are involved that causes cancer clustering, but take as equally important what's going on in the environment. And the environmental characteristics are things that a family can hopefully take some action on if it turns out that they're responsible for some of this family clustering. Now, I know that doesn't alleviate societal problems or alleviate access to such mitigation of risk, but it's information. It gives us a start to try to tackle, at least have the information necessary to try to tackle disparities in cancer risk.
Well, I was talking to the Colon Cancer Foundation recently, and the president, Cindy Barassi, she was talking about that the conversation needs to start with pediatricians. So I guess the point that I'm making is, I think this information should go to the primary care doctors, because those are the people that touch the most patients. So how does your information get to those people, I guess is what I'm trying to figure out.
We do have some educational, a couple of educational websites that actually do have, are permitted for continuing medical education. I can send you a link to that.
Oh, that's great, thank you.
Yeah, I'll send you a couple links. And you know, it is information meant for physicians, but also for families. So it's spoken. These websites are provided in a way that are accessible, I think, to the public, and not just physicians.
So you agree then that this should be disseminated to the frontline providers? This is not just a pipe dream that I have of.
No. Yeah, I definitely agree. And if it's not, then why are we doing the work? Why are we doing the medical research if it's not going to be useful for anybody? And even though, yeah, oftentimes you can't help where you live, you can't help what you eat, and you can help what you drink and smoke and all those other good and bad habits.
Right, and the more you know, and that's why it's important for primary care doctors and pediatricians and gynecologists to be armed with this information, because they're the primary touch points for, you know, the majority of patients. It doesn't frequently get to the genetic counseling stage. That's so much later on down the line, you know, because the primary goal is, okay, you're sick, we've got to figure out how to save you.
Right.
Well, I have taken up so much of your time. Thank you so much, Dr. Wiemels. I really appreciate it. And I hope I will hear from you again when you get to the next stage of your data, the why stage, because inquiring minds would like to know.
Okay, great. Thanks. And yeah, happy to speak with you again, and I'll definitely send you an email with a bunch of information
Thank you
and
so much.
the paper itself.
All right.
Okay.
Great. Okay. Have a great day.
Bye.
Okay. Bye.